Hello everyone, it's a pleasure having you tonight. For those who are on the East Coast time, I see there's a number of people who joined. I'm going to jump right in on today's topic. We're going to go over basic functionalities of VetCAT and take a good look at how we read some cases. And today we'll focus on periodontal disease and endodontic lesions in particular. For those of you who are new to cone beam computed tomography, we have various other webinars that have been posted on YouTube in the past that focus more on the technology. Here quickly you can see the VetCAT in the clinic as it rotates around the patient. It's a relatively simple device to use. It comes to the procedure table, spins around the patient, and the 3D data is acquired on the screen. Before I go into a little bit more details, I just want to remind you, for those who are coming to the Veterinary Dental Forum in a couple of weeks, that will be there at the Dental Focus booth 513. The machine will be there, as well as a couple of us, and we'll be happy to answer more questions. Here's again the VetCAT in clinics. The patient is on the procedure table. When it's time to take a CT scan, the patient is positioned such that we can actually bring the machine around the head, and then we can go ahead and spin the gantry around the patient, and this whole process takes about 30 seconds, and then the images are available on the computer screen within about a minute or so. And really the purpose of this device, this cone beam CT, is that it's available at the right place at the right time, allows you to quickly diagnose, plan your procedure, and go ahead and treat with great precision. And this is the sort of screen you'll see as soon as you're done scanning the patient, so about a minute after scanning has started. You'll be able to see a classic MPR view. We'll go over a bit more details in a little bit, but they are basically the cuts, the various cuts of a CT scan directions, as well as a 3D. VetCAT has now proliferated around the country nationally. We have VetCAT scanners from the East Coast to the West Coast, and a great experience throughout various clinics, smaller and bigger. And there's been a few thousands of patients now treated using VetCAT. Before we go into pathology, I always like to spend a bit of time on describing normal anatomy first, and we'll do that a couple of times just to make sure that we recognize what's normal, because when you utilize a cone beam CT such as VetCAT, there's a lot of anatomic features that you have not seen under such precise image. Keeping in mind that the accuracy of this CT scan is very high. Every cut is as low as 70 microns, typically 0.2, 0.3 millimeters. And of course, you now have cuts of CT in all sort of directions that you're not used to seeing on typical 2D projections. So as a result, some anatomic features that are normal are going to appear very clearly to you. And this is a quick example here. We'll look at that again in a couple of cases. But here is a view of a periodontal ligament around the tooth. It is widened a bit on one side, and that would be normal. This is normal appearance of a periodontal ligament space in the VetCAT cone beam CT. The width of the periodontal ligament is not equal throughout the tooth or between one area and another one, and that mostly has to do with the mobility of that particular tooth. So if there is more trauma from occlusion, normal movement of that tooth, then the ligament obviously is going to be a little bit wider. Another aspect, a question I often get, especially in the beginning when you're not used to seeing these sort of images, is the bone level around the tooth. What is normal, what is not normal is actually is a little different on the CT scan because there's so much information, in particular on the buccal and lingual side of the tooth. So for example, here we're looking at the buccal. This is buccal of this maxillary tooth. The bone on the direct buccal of the root becomes pretty thin, and that's normal anatomy. And its appearance is going to thin out to the point where it starts to disappear a little bit. And one would wonder, is this normal or are we lost any bone? And this appearance right here is actually normal. You can see it on both examples here. You will be able to see various diseases, and we're not going to spend too much time today on root resorptions. This will be for another topic, but I just want to share this with you here quickly. You can now see root resorptions very well. This is in particular, this particular root resorption in this case was actually missed completely on the periapical radiograph. This is buccal, and this is lingual, so you can see how easy it is to not see it on an X-ray. So you can now see and measure resorption as well as the location of it. You can also start looking at periapical areas, and we'll take a look at that a couple times. But when you have such a resorption, you would suspect bacterial leakage throughout the root, and this is a perfect example here where you can start seeing a widening of the periapical area due to pathology. Furcation area, which is of great interest to predict the stability of the tooth in the long term, it becomes very evident and maybe it appears more severe on the CT scan because now we're looking through a cut of roots. As a result, we see this widened area of missing bone. Whereas on a 2D radiograph, because of the projection, it might be more doubtful whether there is bone at some level. So it's more difficult to just radiographically to call this a class 3 or class 2 furcation, whereas on the CT scan, we now have a cut and we can actually study the root buccal lingually and this periradicular space buccal lingually to the point where we can decide whether there is bone there at all. And that will become very, very evident on the CT scan. Another aspect which we'll look at again in a moment on examples is the ability to look at roots in various angles, in particular in the long axis of a tooth. And when it comes to canine tooth, because of its severe angulation, it's often difficult to see and analyze the root in its long axis due to the angulation of the projections of the X-ray. Whereas with a cone beam CT, with the VetCAT CT, it's relatively easy to reangulate the image and take a virtual cut of the tooth in any sort of directions we want. There's no limits to the directions in which we can look at particular anatomy. And here is an example of a relatively young patient, obviously, with wide endodontic space. And again, you can also appreciate while we're at it, the periodontal ligament space, which is not equal all throughout the root, and that's completely normal. And again, you can also appreciate normal bone level. You now see it very clearly. You can decide whether it's normal or not by habit once you've seen it a few times, or if you have any doubt, you can also clearly and easily identify the cemento-enamel junction, the CEJ, which is very obvious here on this particular image, and then take a measurement of the distance between the CEJ and the crestal bone. And if this measurement is within normal limits, then you know that this is normal bone level. Once you do endodontic treatment, you can take an image again, take a CT again, because it's relatively quick to do. And And here's an example of a VetCAT cone beam CT taken after an endodontic fill. And it allows you to now discover maybe voids if you've left them behind. Taking a CT is certainly very humbling because you'll see this sort of situation more often than not. Whether it's something you need to retreat or not is up for debate. Of course, in this particular area of the root canal where it's very much coronal, there's probably not much to worry about. But more interestingly, it's now possible to verify the apical area of the endodontic treatments, whether it's complete, whether there might be a void in that area. In this particular case, this was done very well. And you can actually also see the cement projection throughout the apex. In fact, there's a couple of those in a couple of different directions, which indicates that there's at the apical area, there's more than one canal, which the little delta area is very common. And you start actually observing this sort of image, which in this case is a good feel on the cone beam CT quite easily. You can also see where the apex is. And if you imagine where a periapical X-ray would be, again, this is buccal, this is sort of lingual on this side, you can easily understand that the projection of the gutta-perca onto the root would make it difficult to decide where the end of the gutta-perca might be. Whereas with a VetCAT CT, you can see it very well. There's also the ability to do 3D reconstruction. We'll skip that today as well. But the 3D is a nice tool to evaluate bone loss as well. In this particular case, this is a very severe periodontal bone loss, obviously. It's maybe not as useful at the time of diagnosis because the cuts are so precise. However, getting the 3D gives you directions in space so you know where you're at, in particular in the beginning of the use of the machine. It is also a very nice illustration for the owner. You can show them this 3D picture and they will clearly understand more obviously the amount of disease present by just looking at this picture. Whereas the cuts, of course, are very difficult to read for non-specialists. There are many more details and areas of interest. Here's just one other example of a severe periodental lesion. This endodontic lesion has actually reached the nasal cavity, and there's now communication, oral nasal communication, which is causing a good amount of inflammation nasally. In fact, this patient presented with nasal discharge. That was the chief complaint. But by taking a CT here, you can see the relationship quite easily. Here is on the B panel a cut of that area, also very thin cut through the CT scan. We'll look at our directions, but this is front and back. This is distal. And on C, this is buccal and lingual, obviously. If you had a projection like we have on the panel A, because this is an advanced case, it is obvious that there is disease, but the exact amount of communication and the relationship between the root and the nasal cavity is less obvious on an X-ray, whereas it becomes very, very significantly well documented on a CT scan. So this is in short what VetCAT can do, and I suggest we now jump into some cases and start to navigate through some cone beam CTs on VetCAT. Here's a VetCAT database, just exactly the way you'd see it on your machine. And we're going to go ahead and open a case. I always like to start with a normal patient, again, to look at normal anatomy because it's a bit easier to first learn normal before looking at disease. So let's take a good look at that. And here is an example of normal anatomy, where you can appreciate the various panels. Give me just 1 second here. I see a couple of people are joining, so I'm going to pause this for just a second. I'll be back in just a moment. Sorry about the interruption. There was a couple people that I want to make sure were able to jump in on the call. There's a number of folks that were that I had to let in. So let me go back to the cases here. Again, this would be very much what you'd see on your VetCat. When we go to a normal anatomy, we're going to open this case together and take a look at it. And this is the sort of image we would first initially visualize. And just to give you orientation, we have the axial view, so the front to back cuts, coronal view, which is sort of looking at the patient from the top or bottom, and then the sagittal cuts. I like to travel initially at first when the case comes up on the screen. I like to travel on the axial view and start from the front. And there's several ways to do this, but just quickly, we're going to look at cuts. Remember that these cuts are very thin. In this particular case, they're every 0.3 millimeters. We can scroll through the anatomy from the front to the back. And once you're used to looking at this, this is a quick way and relatively efficient way to identify disease in a quick manner at first. What I'm going to do now is just point to normal anatomy again, because here in this particular patient there is no disease. What I want to show you here is those ligament spaces, which are easy to see. Of course, this is a relatively young patient, so the endodontic spaces are very wide. You can see the furcation areas are closed, bone in between the roots. And this would be the normal sort of bone level to expect. If we zoom in, we can actually zoom in pretty precisely. And this is the sort of bone level you would expect around the root. This is buccal, this is lingual. What we can then do is look at our coronal view and trace a panoramic image. And here I did it ahead of time, but it's very quick to do. One of the tools, the VetCAT tools, is available right there on the screen. By the way, everything is right here on the screen. There's just a few tools to be utilized. This panoramic tool is such that we can trace the arch quickly. Let me do this now with you so you can see how to go about it. We're going to trace the arch sort of vaguely going through the roots buccal lingually. And when we're done, we'll just double click at the end. what will then appear on the upper right quadrant is a panoramic view of that arch, of, in this case, the maxillary arch. This is a convenient visualization of all teeth now lined up on one screen. And if there was bone loss or some sort of lesions, they would come up here quickly. So this is another quick way to see pathology. The next move, so to speak, is to actually now look more carefully at some details. We can travel through the panoramic view, and when we do that, on the lower right quadrant, we now see cuts of the roots and the teeth as we travel from right to left or from left to right. This is buccal, this is lingual. So when I move this line here, we're actually traveling by looking at buccal lingual cuts perpendicular to this dashed line. And that is another way to be able to see bone loss and periapical lesions in a very efficient way. So let's take a quick example here and assume that we are interested in looking at this canine, this left maxillary canine, and we want to take that into consideration and look more carefully at a particular pathology here. What we would then do is make a section of it virtually. So now I'm cutting this tooth buccal lingually, and very quickly this will come up on the screen. We now have a buccal lingual cut of that particular area as a separate image, which we can keep and analyze more carefully. And again, here's the periodontal ligament. This is bone level on the direct buccal. This is buccal. This is lingual. This time we're cutting that tooth virtually by using this line. And if I move this line, I will cut this particular anatomy differently. So I can certainly move this, and you'll see that the right quadrant changes accordingly. And we can go on like this just as much as we want. In fact, we can make a cut of an entire arch as well if we wanted to. So if I now take a cut of the left portion of the arch, I now have what almost looks like a side projection of these teeth as well. So we're completely free to make cuts of roots in particular in any way, shape, and form we want to. And by the way, if we see something of interest and we now want to save that image to export it into a report, all we have to do is select it. It will now be saved on the lower right quadrant. And from there on, there's another button to push when we're done selecting images. We'll export all of those panels into a folder. Probably the most convenient way to go about this is to send those pictures into a JPEG. You can then copy them and attach them to a report to the owner or your referral. So this is a quick way, a relatively efficient way to observe the anatomy and find pathology. With a little bit of use and practice, this whole sort of workup will take a few minutes. What I've observed with VetCAT users is typically after about maybe 10 to 30 cases, so just a few days, it takes somewhere between 3 and 5 minutes to do what I just did. And now you can move on to the treatments. What I will now do is pick up a couple examples of pathology patients. We wanted to spend a little time on endodontic lesions as well. So here's one. This is coming from Dr. Ballen's office. I see Mary is here on the phone, so Mary is here. So here is a patient who received a CT scan before and after root canal. And there was some I believe there was some superficial fracture of this crown. But let's take a good look at this. This is before treatment, obviously. Again, the coronal view, axial view, and sagittal cut. We now have a few more people coming in, so let me make sure I let them come in. And what I want to show you now is we've traveled through the cuts using the axial cuts initially. And if I turn this 3D around so you can see it a little better, I'm just going to give this orientation here so you can see where I am at. I'm going to look through cuts, and if you follow that green line going back, I'm traveling through the cuts and anterior posteriorly. And I like to do this because you can quickly see disease. Now, I can do the same all the way across, but I'm going to stop right here in these endodontic areas, and some of you probably already know that there are the differences between the left and the right endodontic spaces. And if we zoom this a bit more, this is interesting because we notice that the endodontic space is much darker on the right side than it is on the left side. If you're not sure which side you're in, by the way, it could be slightly confusing at first when you first learn because the CT scan is oriented in such a way that the left is on this side. Left and right and other orientation is always labeled on the CT scan, so you'll find the L for left. So in any case, these endodontic spaces are different on the left and on the right. As you know, there should be tissue, blood vessels, nerve endings, and such in the endodontic space. And as a result, you'd expect this to not be completely dark, because dark means there is nothing in it. And you can see here this endodontic space compared to its neighbors, for instance, compared to the opposing tooth, is telling us that this particular tooth is necrotic. The tissue has died off within the pulp, and there's no vitality in this root canal, and you can see it very well here. In fact, if you look more carefully in great details, which we can do, you will notice that there are parts of the pulp that are still occupied, as you'd expect it. In fact, as we make our way to the apex, we'll probably find tissue, and here it is. You can see here that there's still some soft tissue present. But obviously, this root canal is no longer vital, at least in great part, and we can now go ahead knowing that we do need to proceed with treatments. And what we can also do is travel to the apex of the root, and that's what I'm doing here. I'm sort of moving up more apically. And of course, the apex is going to be more distal because of the angulation of the tooth, but being a cone beam CT, that doesn't matter because we have it in 3D. And now what we're able to observe on this image is the difference between left and right in the periapical area. And we can now see very, very well that there is increasing space and the beginning of a leakage and the periapical lesion developing on the right side. All of that is very obvious on the CT scan, and sometimes a bit surprising how easy it is to see because it's so large. And you can see it here pretty well. We can also take a look at this periapical zone in the sagittal view, and we can zoom in all the way to the point where we now see this periapical lesion in this cut. On a 2D X-ray, this would be a lot more difficult to see because that lesion hasn't reached the cortical bone yet. So there's a good chance that the lesion itself, and maybe even that space, the differential in space density, would be a lot more difficult to observe on a regular X-ray. So let's go ahead and take a look at the post-treatment scan. The VetCAT can stay connected somewhere else in the area in your room. It works on batteries. You can just grab it from a corner and bring it back. And here is the same tooth, but this time we're looking at it after treatment. And obviously, this is the gutta-percha feel. If I turn this off, you can see it a little better. We can appreciate the nice feel, very homogeneous. This little dark lines around this very white dense area, that's normal. That's actually a specific artifact to CT scans. It's less significant on cone beam CT than it is on conventional computed tomography, but you'll see this little sort of dark shadow due to the X-ray system. But then you can certainly focus on the apex area, and here's a very nice feel. It ends exactly where it should. If we wanted, if we were curious, this is not so important here, but if we wanted to, we take a measurement. We can measure the end of the feel to the anatomic apex. And here we have 1.53 millimeters. These measurements are accurate in all directions. So if we change the measurement in some other way for whatever reason, then there's no distortion in whichever way we look at this. So if we somehow are interested in the width of the root in this area, that measurement is correct. So this is a very elegant way to confirm treatments and appreciate the endodontic outcome in all directions. Of course, this is just after treatment, so the periapical area hasn't changed yet. But if we were to wait a few months, or maybe a year, and wanted to retake a scan, we would then be able to compare and contrast the healing of the periapical lesion over time. What I'd like to do for the next few minutes is focus now on periodontal disease. So let's go ahead and just open a case together and take a look at what this is presenting. Again, you'd be scanning the patient 20-30 seconds, and then the patient scan would come up on the unit. And here's an obvious lesion. I prepared it ahead of time to show you, but this is what you'd see initially. And again, I like to travel from the nose back. I'll bring up the 3D so you can see it as well. And as we make our way back, we will now see bone loss in various areas. So for example, as compared to what we saw earlier, we can now decide if this bone level around this root, for instance, is normal or not. Obviously, the root canal area is much smaller. This is an older patient. But if we have any doubt, because this cut of the root now is not in the long axis of the root itself, and we're not sure whether this bone level that we now see is normal or not, one way to go about it is to look at the CEJ and see where that ends, and then decide where the bone level starts. And as long as we see a reasonable distance, then we know that the bone level is minimum or absent. Interestingly, though, what we can start to see in this particular case are very subtle other issues that would otherwise be more difficult to see. For example, we jump in the coronal view, and all of a sudden we notice this concavity in the root, which would be very easy to miss on a regular radiograph. But this root here is presenting with the beginning of root resorption. So whether we want to intervene and do something about it is another question, but certainly this is now jumping at us, and we can look at the root resorption in different sections. If we now go to the sagittal view, this is buccal, this is lingual again, and we can now see the root resorption more easily, something that we would probably have missed if we were to look at two-dimensional projections only. Let's go back to our scrolling from the front to the back. And with a little bit of habit, those sort of lesions jump at you more easily. Of course, we see here significant bone loss. This is buccal, this is the suture. We do see that there is significant bone loss in this area. And we make our way back. Clearly, this lesion now, this is for another day, another discussion, but this sort of destructive bone loss is pathologic as compared to the contralateral crest, which is normal. And we keep making our way more distally. We can see the roots in the long axis. And in this particular tooth area on the left side, we have this very obvious and relatively localized severe periodontal disease. And if we're not sure, we can compare with the opposite side, which will give us a good feel for what to expect if it was normal. And here we have significant buccal bone loss. This is buccal, this is palatal. And as we make our way more distally, we can visualize the amount of bone loss around this root. There's a couple little details that we see now more easily on the cut as well. And here's just an example. In this case, we can appreciate an intra-bony defect palatal to a root, something that would be hiding from us if we were to look at a projection. Of course, this is a large lesion, so it's relatively obvious, but we'll see this sort of isolated lesions, sometimes associated with root resorption, like we see here, on the direct palatal of a root. We can sort of zoom onto this one spot and jump to it and make a cut of it like we did earlier. Move this cut around as we want it, and save this image if we want to save it for future use and for reporting, where we can now see the defect. If I move this cut, artificial sort of cut buccal palatally, more mesially, so I just grabbed the whole line and moved it, I'm now looking at a cut throughout this line, which is represented on this right quadrant, and allows me to see this large defect that invades the root almost to the buccal area, but it's certainly more centered towards the palatal space. And if I want, I can change the angles of it to get a feel for the exact anatomy of that defect. We can always go back to the basics and sort of recenter ourselves if we're a little bit lost. And this is, I just jumped right back to the very beginning of the scan itself, the way it would present if you had just scanned the patient. This is what you'd see exactly, just not those cuts here. Let me take this out. So this would be, again, how the patient would present on the images as soon as the scan is completed. And from there on, we would look through the actual views. This is what I like to do. Seems to work pretty well. We would then, after we've quickly seen a few problems here and there. Here's one of that same defect again. We would then go ahead and trace the panoramic view, which would show us some of those defects, in particular this one isolated defect. And here's the panoramic view. And if we feel like we should change this image a little bit, because this panoramic view does not travel through exact anatomy like we want it to, we can just grab the various points of it and change that, or maybe move the whole arch itself. So we can fix this as we go. Again, this is just a software tool, so we can do it again if we have to. I'm going to go to the mandible actually and hide this for a second so I can show you what the mandible looks like. Of course, we now have this large, very invasive lesion, which is very much worrisome. But if we wanted to trace the panoramic cut, we would go ahead and do this very quickly. And we could now see this mandibular panoramic view, which interestingly, something I hadn't seen before. Just a moment ago, I didn't go far back here, but this panoramic view makes this lesion jump at me immediately. We're on the left side, and I can see here that there's significant bone loss around this root, something that I didn't see just earlier as I didn't travel all the way back. But now this is going to be very, very obvious to it. And of course, we have this large defect. I'm going to turn on the sound, by the way, in case there are questions. You might hear some background noise. I just want to make sure that as we are sort of wrapping up, if someone has questions, you can go ahead and shout them in the microphone. It should come up. Here's another one here. I'll just open another case so I can show you. Any questions from the audience? I see quite a bit of people here. So again, I like to travel from the front to the back. Very severe case. I think it's very telling here as we're making our way back. I'll turn the 3D as well. There's some significant bone loss. Of course, there's already past extractions and so on. But here we can see very significant loss. And by the way, it's relatively easy to change the contrast. So I'm adjusting that so you can see how it works. But here is a tool that basically soft tissue. Mostly there's very little bone attachment remaining. So here's a very severe case. Of course, a lot of extractions already. I'll show you a relatively recent case. This is Dr. McTaggart in Canada. Probably one of her first cases. She had just started not too long ago. And I see a question here coming up. I'll answer it in just a second. This is really interesting. Question is, do you do 3D X-ray still, or just 3D? And still a bit of a debate here, but the studies that are coming out sort of points to the idea of using 3D in place of two-dimensional radiography for brachycephalic patients. For others, still a bit, have to debate whether you want to use this exclusively. I think there's still room for 2D, of course. The cone beam CT might not be needed at every single patient, but certainly you'll be able to start seeing that was otherwise hiding. Just want to show you one more case. So again, I'm going to go from the nose, make my way back. Let me change the contrast here so you can see it a little better. Do this one more time. And as we make our way back, we can appreciate the anatomy. Any other question from the audience? I see we're still there. So if you have any questions, please go ahead. You can either type them or just shout it in the microphone. I think that works pretty well. So again, just want to show you how we travel through the anatomy very quickly in all directions, from the front to the back, or up and down. And make this a little bit more obvious for the internet. That tends to show it better. So again, we go front to the back. We can travel quickly. And I'm just waiting here for a second until everybody has a chance to. I'm going to slow down a little bit, so everybody has a chance to look at this cut and see if you see anything unusual here. This is not really a test, but it's interesting that you start to get used to seeing. What jumps at me here is lesion right here, this cystic, what looks to me like a cyst lesion. It's certainly not normal. This is normal. This is the nerve bundle. This isn't. If you're not sure, then symmetry is your friend, because you'll be looking at the opposite side, looking for the same. The question here in this case that came to me was, is this, what sort of lesion is it? The question wasn't whether there's a lesion. The question was, what is it? To me, it's an obvious cyst for many reasons. One of them is it's not invasive at all, like we saw earlier. It is displacing the bone, but it's otherwise this very clear balloon-looking lesion with nice cortical bone. It's not sort of bubbly or destructive on the surface. So I'm looking at a typical cystic lesion with well-defined borders. Where the center of the cyst might be and where it's coming from, that I'm not entirely sure. This could be the lacrimal canal, it probably is. It could be also from the orbit. But this is the sort of lesion that you're going to start to see on a regular basis. Another question here. Sorry, I couldn't see it quickly enough. So it looks like the contrast maybe not showing well on your side. We can change the contrast as we wish, and very often it will depend on your screen and your room lights. So I'm sort of playing with this a little bit so you can appreciate how easy it is to change. But there will be differences in contrast from screen and from room to room. But we can certainly save this preferred contrast very easily. Just go right here and save this current contrast and call it whatever we want. And from now on, we have it saved as a reference. That could be useful if you're using your VetCAT in different rooms in particular, and you want to go to a darker room or a more a clearer room. You might want to use a different contrast as you're changing rooms. Okay, I think we've covered quite a bit. We've looked at we've quickly saw how to at least initially go through a case and realize that with a little bit of habits, within a few minutes, we should be able to analyze and pick up some obvious pathology. We can then trace the panoramic plane, which is another way to look at disease, and look at details of pathology by doing cuts. I thank you for your attention. This webinar is good, so if you're interested, it will be posted in just a few days. You'll be able to get back to it, and you also will receive an email with your ability to send questions. I thank you, and thank you again for attending tonight's seminar.
Thank you, David. Appreciate it.